Dr. Carlo Oger, emergency physician with DrER.tv. If you're watching this video, you are at ADX Video Pro, my channel for medical healthcare providers who want to learn, medical students, paramedics, nurses, whatever. This is kind of a rare case. I've seen it once or twice, and we're going to talk about it. So here we go. This is a 75-year-old woman with recent urinary infection, presented with recurrent abdominal pain, vomiting, weakness, confusion. She also had orthostatic hypotension, which means when she stands up, her pressure drops quite significantly, and bradycardia, slow heart rhythm, less than 60 beats per minute. Her medical and family history was unremarkable, and she was receiving no medications. Physical examination showed no abnormalities except for moderate quadriparesis, so she was paralyzed, and abnormal behavior and hallucinations. MRI and abdominal computed tomography, a CT scan, gastroscopy, colonoscopy, all normal. But she had abdominal pain, so how come the CT, endoscopy, colonoscopy are normal? I don't know. EMG, electromyography study, showed an acute motor neuropathy, and CSF, cerebrospinal fluid test, revealed high levels of protein. Laboratory test showed a low sodium, 124 is pretty low. Normal should be like 134 or so. When a urinary catheter was placed, dark urine that was reddish. Urine was drained in the urinalysis, but it showed no blood or pyuria. Pyuria means white cells in the urine, signifying infection. So no blood and no infection, but the urine was very red. Here's the urine on the catheter, on the bag anyway. That's what it looked like. This is the blood tube that went down to the lab. You can see it's very red. So patient has acute mental status changes, some kind of neuropathy. MRI, CT scans are negative. She has what looks like blood, but not blood in the urine. What is it? Diagnosis is acute intermittent porphyria, confirmed by increased urinary excretion of porphobilinogen. She was treated with hematin and adequate calorie intake, and symptoms resolved in 2 days. Acute intermittent porphyria is rare, autosomal dominant, so there's usually a strong family history of it. Metabolic disorder of the heme synthesis because of deficiency in porphobilinogen deaminase enzyme. It shows low penetrance, and those might not appear in every generation, but there's usually some family history. So a continuation here. I had a little pause there. So clinical manifestations vary and consist of abdominal pain, peripheral neuropathy, orthostatic hypotension, which she had, hyponatremia, and mental disturbances. High index of clinical suspicion is important to avoid delayed diagnosis. Drugs, alcohol, fasting, stress, and infection are most common precipitants for an acute attack of acute intermittent porphyria. So you have a patient with altered mental status, paralysis, abdominal pain, and the tests are all negative. The urine shows bloody urine, but the urinalysis is negative for blood. Think about this diagnosis, acute intermittent porphyria. Again, there's a strong there's a family history because autosomal dominant, but because of the low penetrance, it might not be immediately clear that they've had a history of this. So just consider this diagnosis, acute intermittent porphyria, because without adequate treatment, patient will continue to have these altermentation changes. People will label the patient as psychiatric, or that it's not real, or something's faking. And as you can see, there are many triggers like drug, alcohol, fasting, stress, and infection, common triggers of this. All right.